So Dr. Hari is our nuclear oncologist at Mary Bay Perkins, currently seeing his patients at our Gonzales location. He's spearheading all the efforts for our Theranostics program, which is growing faster and faster. So, oh, dang, I didn't bring my glasses. The targeted revolution, perfect, oh, per Hari. So, is that what it is, more or less? I cannot read it. Sorry about that. There is a misprint? Dr. Hari?
Hi, I'm Adithya Hari. I'm a nuclear medicine, nuclear oncology, and theranostics. I practice at Mary Bay Perkins Cancer Center, and I do research in Pennington Biomedical Research Center. Thank you so much for attending my talk. I have nothing relevant to disclose. Some of the topics that I wanted to cover in this talk are more focused on theranostic agents, what's approved and what's in the pipeline, and a few points about what we are doing in terms of workflow optimization, and technologically, what are the advancements out there. There has been a steady increase in theranostics market over the years. It started mostly around 2020. That's when Lutathera was first approved by FDA. It was approved in 2018, but all the institutions managed to bring it up and internalize within their own practice. And since then, it's been increasing and projected to increase exponentially for the next 10-15 years. There are multiple conferences that focus just on theranostics, starting with SNMMI, ICPO, targeted alpha therapies, ASTRO, and even today we have at least 3 theranostics talks happening in parallel, the first 2 in the genitourinary section. Radiopharmaceutical is a combination molecule. There is like a carrier molecule and there is a radionuclide that's attached to it. So this carrier molecule seeks wherever the target is and it drags the radionuclide along with it, and that's what we do in nuclear medicine. We use radiopharmaceuticals. Can be used for diagnostic purpose or for a therapeutic purpose. And there are multiple AKAs for theranostics. People use radiotheranostics, targeted radionuclide therapy, molecular radiotherapy, etc. So conventionally, the cancer management is either through chemotherapy, surgery, or radiation therapy. And surgery and radiation therapy is mostly reserved for cancers that are localized, and you have some local regional spread, but chemotherapy is usually utilized when there is much more widespread disease. Theranostics, it offers a distinctive systemic therapy alternative to chemotherapy. So the theranostic agents also go wherever the chemotherapy goes, but instead of doing its pharmacological action, it does its radiation action. So theranostics is a combination of diagnostics and therapy. The receptor for the cancer would be the same. Ideally, the linker molecule should be the same, and only different should be the radionuclide that's involved. A weaker radionuclide is used for radioisotope is used for diagnostics, and a much stronger radioactivity is used for therapy. One of the oldest theranostic agents that people everywhere use is radioactive iodine. It's like a salt pill, but instead of sodium chloride, it's sodium iodide, and instead of normal iodine, it's radioactive iodine. And this has been used to diagnose and treat thyroid cancers. For example, you see here that I-123 sodium iodide is it's like just a gamma emitter, and it is used to see the extent of disease. For this patient, fortunately it's only reserved in the neck. while I-131, which is a beta emitter, it's used to kill the disease. And when the patient ingests I-131 sodium iodide, it also goes to wherever the disease is, but now it's trying to kill the cancer. This is the most recent classification of thyroid cancer given out by American Thyroid Association. It came last year, and it provided a clearer categorization of various differentiated thyroid carcinomas depending on their rates of recurrence. It's categorized into low, low intermediate, high intermediate, and high. And various characteristics of the cancer goes into these characterizations. For example, how big the tumor is, or if it is unilocal versus multifocal, or if there is lymph nodal spread, or if there is distant metastasis. And radioactive iodine therapy is suggested for intermediate and high, and of course for distant metastasis. It's not suggested for low, for diseases with low rate of recurrence. A second good example is the use of bone scan for diagnosis of bony metastasis and radium therapy for treatment. It's not technically a theranostic agent because bone scan uses a different agent and radium-223 is a different agent, but more or less conceptually it's similar. ALSINCA trial was the first clinical trial that showed benefit in survival metrics using radium-223, and this has been used since last 15 years. Radium is a calcium mimetic, so it goes wherever calcium goes, and bone scan is used to see the eligibility and the response estimation done with radium. So on here you see a baseline bone scan of a prostate cancer patient with so many bony metastases, widespread metastasis all over. And after 6 cycles of radium-223, you can see that all these hot spots, they are less intense. So there is decreased extent of bony metastasis altogether. The newer agents are engineered in a different way. So you have a cancer cell. It expresses a certain receptor. So the theranostic agent is designed in such a way that there is a agonist or an antagonist or an antibody to that receptor, which is here in green, and it's linked to a radioactive isotope. For example, here gallium-68 is a diagnostic isotope, and indium-111 is a Auger electron emitting theranostic isotope. So you can think it of like a train which carries so much coal, right? So the engine is the agonist or the antagonist, and the cars are filled with radiation. So the engine goes and stops wherever the train station is. So that the train station is the cancer molecule. So wherever the engine stops, the coal is delivered, the radiation is delivered. One of the first examples is gallium-68 dotatate. The dotatate is a somatostatin receptor 2 agonist, and the binding efficiency is super high, more than 95%. And it's used in neuroendocrine tumors. For example, here there is a patient with neuroendocrine tumor imaged with FDG PET versus gallium-68 dotatate PET. And when you compare both of them, you can see that the gallium-68 dotatate has much more contrast, have more signal to noise, and it can give a good extent, a true extent of the disease. FDA in 2018 has approved Lutathera, which is lutetium-177 dotatate, and this is for the treatment of metastatic gastrointestinal and pancreatic neuroendocrine tumors. So lutetium-177 is a beta-emitting radioisotope and also emits gamma. So the beauty of it is it can kill the cancer, and also you can use it to image where the lutetium-177 dotatate is going. On the left-hand side, you have a gallium-68 dotatate PET scan used for diagnosis of this patient, and also to see if the patient is eligible for this therapy. And you can see that with the lutetium-177 dotatate, it's given in 4 cycles. After the first cycle, when you image the same patient, anterior and posterior, you see that the lutetium-177 dotatate is going to the same places where the gallium-68 dotatate went. And at the end of 4th cycle, you can see that the intensity is decreased. So the cancer itself is reducing in size. You can see that in real time. And this is a different patient. In the baseline gallium-68 PET scan, there is widespread bony metastasis, widespread disease in the lymph nodes and in the liver. And after 4 cycles of Lutathera, a repeat PET scan is showing that most of the lesions have disappeared. Some of them have decreased in size. And NETR-1 trial from 2017 showed that there is huge progression-free survival benefit with lutetium-177 dotatate. The other FDA-approved theranostic agent is PSMA. It's a membranous protein expressed in most of the prostate and also exocrine secreting cells, but it's upregulated in metastatic castration-resistant prostate cancer. So it's about 1,000 times more in castration-resistant prostate cancer, particularly when the patient has failed a couple of hormonal therapies and probably chemotherapy. And you can see here that when the tumor load is increasing, when the PSA is increasing, that's when the PSMA PET scan is much more beneficial. That's where its true value lies. And lutetium-177 PSMA is the theranostic counterpart for this, for the same target, and it's been shown to increase progression-free survival and overall survival for these patients. This is an example of a patient with widespread bony metastasis from prostate cancer. This is the baseline scan, and we had a repeat PET scan done at the end of 3rd cycle of Pluvicto and also at the end of 6th cycle of Pluvicto. You can see that some of the lesions, for example, the one on the top of the head and along the vertebrae, some of them have resolved and most of them have decreased in size. So it's much more easier to handle this disease right now. There is so much research happening in the world of theranostics. So it goes from detecting which specific receptor is most appropriate for imaging and treating a particular cancer. So what's the specific receptor? What's its agonist? What's its antagonist? Or an antibody? What's a good linker molecule? And what is the good radioactive compound that goes along with it? Is it a beta therapy? It is a alpha emitting agent, or is it a Auger electron emitting agent? Stuff like that. And here is a snapshot of all the new radiopharmaceutical trials out there. The outer circle is the chemotherapy, and the little donut, the inner circle, is the radiopharmaceutical trials, the theranostic trials. And you can see that the green part, which is about 9%, that's those are the phase 3 trial, and it's mostly with PSMA and somatostatin analogs. And majority of the agents are still in the early phase clinical trials. And on the right side, you see the spread, the various targets that are being explored in relation to each cancer. And some of the actively pursued molecules are FAPI, which is fibroblast activated protein, or GRPR, gastrin-related peptide, and also some PAR. I'm going to give a couple of examples of what's coming down. FAPI, so think of this as spaghetti and meatballs. So cancer is comprised of cancer cells, which are the meatballs, and so much of stroma around it, which is the spaghetti around it. So the stroma is made of these fibroblasts. These are called cancer activated fibroblasts, and they are the essential ones which make up about 80% of the tumor environment. Only 20% is the cancer cells. FDG, PSMA, dotatate, all these are used to image the cancer cell, but FAPI is the one that's used to image the stroma that's supporting all these cancer cells. And they are much upregulated in not only in cancers, but also like autoimmune diseases or anything that causes some fibrosis. Here is an example of a female patient with sarcoma of the left breast. When you compare it with FDG, the FAPI on the right shows more number of lymph nodes, so it reveals the true extent of the disease. And probably the FDG, the sensitivity of the FDG is lower in places where the size matters. And on the right, you see a patient with esophageal cancer. The state of the art FDG is showing a avid circumferential tumor in the distal esophagus, while with FAPI, you also see the esophageal cancer, but then additionally you see this lymph node, and that that increases the staging of the disease. And the beauty of gallium-68 FAPI is you also have a theranostic component, which is lutetium-177 FAPI. And this is a patient with medullary thyroid carcinoma with widespread bony metastasis and osteolytic lesions all over. And when treated with 6 cycles of lutetium-177 FAPI, you see that the cancer is much more manageable and more, you get a better handle on the disease here. And here is another example of lutetium-177 FAPI. Oh, thank you so much. Sorry about that. Here is an example of lutetium-177 FAPI being used in iodine refractory thyroid cancers. For a very long time, we had the pleasure of treating thyroid cancers with iodine because they are essentially, they take iodine, they destroy themselves, and we are fine with that. But the real problem starts when they start to de-differentiate and become refractory to radioactive iodine. So here is an example of a patient with extensive disease within the neck with multiple lymph nodes that's highly FDG positive, so they are likely iodine negative. And with so many cycles of lutetium-177 FAPI, you can see that the extent of the disease is much decreased. And there is almost 90% decrease in circulating thyroglobulins. Another molecule that's out there about to come out is gastrin-releasing peptide receptor. It's also known as bombesin, and it's overly expressed in some of the most common cancers like breast, prostate, lung, and gastrointestinal tract. So GRPR is particularly useful in prostate cancer, which is PSMA negative, and low-grade prostate cancers. And also in breast cancers, which are much more, which do have more estrogen receptor positivity. And there is a trial that's happening elsewhere, and it's about to come to the US, where the bombesin receptor is being targeted using copper 64. That's the PET agent, and it has a theranostic component. It's copper 67. And these represent a true theranostic, an ideal theranostic agent, because the antagonist and the linker molecule would be the same. The only difference would be copper 64 versus copper 67. That's combat trial, and I think it's still ongoing. And for example, here you see a prostate cancer patient who has completed all the 6 cycles of Pluvicto, and now you see that there is maybe one mildly avid upper abdominal node, but a concomitant imaging with copper 64 bombesin shows that there are multiple such nodes around the liver and the upper abdomen. So it's more used in PSMA negative disease. Now switching gears, along with the new availability of all these theranostic agents, there needs to be some changes in the referral patterns and the patient management. At Marybird Perkins, we have tumor boards for active discussion of patient management, where actual referrals happen from surgical oncologists, urologists, medical oncologists, endocrinologists, head and neck surgeons, dentists, and that's where we procure the patients from. And a core theranostic team comprises of a nuclear medicine physician, dedicated nurse navigators, and nuclear medicine technologists. So we are responsible for initial counseling the patient to discuss the pros and cons, and then insurance approvals, and then also measuring the efficacy versus toxicity of the theranostic agents. So during the actual delivery of the theranostic agent, we also require support from radiation safety, physics department, and also a dedicated clinical coordinator is needed, because there are so many appointments to keep track of, and so many reminders for both the physicians and the patients and their families. So when the patient is initially referred for theranostics, we have an initial consultation. We discuss what it entails, what it takes to get through this treatment modality, the risks and benefits. The treating physician will independently review the imaging findings, the PET scan, to determine the eligibility, and then seek insurance approval. And during the treatment cycles, there should be post-therapy scanning, ideal for dosimetric analysis and also to assess for radiation safety. And long-term follow-up will be needed to assess for response and to also evaluate if there are any toxicities involved. So to be able to do this, we need access to a hot lab for safe dispensing of radiopharmaceuticals, a SPECT CT to be able to image right after, because all these theranostic agents, while they are able to effectively treat, like deliver killing dose of radiation to the cancer cells, they can also be used for concomitant imaging, and that's how it's designed. And this post-therapy SPECT CT, there is a way to use it for dosimetry and assessing for effectiveness while the patient is receiving therapy. And also there needs to be a dedicated therapy room with access to a bathroom that's specifically reserved for radioactive patients. Here you can see me injecting Pluvicto, and this image was taken through a specialized radiation detector camera, where we detect radioactivity and it's overlaid on the patient. So it's a way to say that the radioactivity is effectively in the systemic circulation. The other technological advancement is the use of post-therapy dosimetry. Lutetium-177 can also be imaged. So you can see that this is a post-therapy image done after the first cycle where there is no response yet. And the second set of images are the SPECT-CT done after 3 cycles of Pluvicto, so where you can expect to see some response. The software automatically contours whatever signal it finds apart from the normal organs, and you can see that there is so much decrease in the red when compared between cycle 1 and cycle 3. And research has shown that this decrease in the tumor volume it translates to survival probability. With the new software, the field is more moving towards adaptive dosimetry. For example, for now, we treat all the patients using empiric doses of radioactivity. And the field is more moving towards tailoring the dose to each and every patient. For example, the patient will receive an empiric dose of radioactivity the first time, and judging by how much the dosimetry wise, how much the organs are receiving, how much the cancer is receiving, and the patient's maximum tolerated dose, the radioactivity can be decreased or increased for appropriate patients. And this is the latest advancement in the era of artificial intelligence and computational nuclear oncology. This is called Theranostic digital twin. In this, during radiopharmaceutical trials, when you take the data from the patient individually, you also take different characteristics of the radiopharmaceuticals, like the pharmacokinetics, the radiosensitivity of each and every patient, the various functioning levels of organs, and their individual immunological reactions. And all these will be combined during the clinical trials, and it acts, and the AI tries to integrate all these findings for each and every patient, and that will be used as a new standard for designing and also implementing clinical trials from now on. Just in conclusion, as you may have seen, that most of the references that I've put has come out in the last 5 years. So the field is pretty new, and it's sexy, it's exciting, and so many multiple agents are coming out. There are beta emitters, alpha emitters. They can be used as a solo treatment option, or combination with external beam radiation, or combination with chemotherapy. And when you compare it with other chemotherapy drugs, most of the times the radiopharmaceutical drugs are more or have a better tolerability, have a less side effect profile. And the advancements in technology and computational levels towards quantitative dosimetry and personalization is much more exciting here. Thank you so much.